Ready? When we look at the body, there are many organs and organ systems that comprise the body. But when we ask the question, what is the largest organ in the body? What would you say? What's the largest organ in the body?
The skin or skin.
The skin. Very good. Very astute group. So tonight we're going to be talking about skin. The skin is the largest organ of the body. And from an embryologic perspective, when we talk about embryology, when the body is forming, the skin is actually the same germal layer as the brain and central nervous system. Okay? So the skin actually becomes a window into the brain. Meaning, if the skin is really dry, the brain is dry. If there are a lot of lesions or brown spots starting to form on the skin, the brain is also starting to form lesions. When we start to see the skin withering or drying, the brain is also withering and drying. Isn't that fascinating? So from a germal perspective, an embryologic perspective, the skin is a direct window into the brain. Okay? Now different presentations of skin, as we understand it, actually begin then, and let's actually look at just skin as, first of all, a layered system. Let's talk about the fact that on the outer surface of the skin is what we call epidermis, the dermis, and then there's a basal or a germal layer. Okay? And in essence, what we see is the epidermis is non-living, the dermis is living, and then this germal layer, there is our blood vessel, and then into the dermis comes then some of the nerves, and then the dermis itself, small capillaries, but also then hair follicles that actually come up and erupt through the epidermis. Okay? Where are locations in the body where there's actually bone erupting through skin? Your teeth. Very good. So your teeth are actually extensions of bone, in essence, that actually erupt through skin, and a small ligament creates a seal through which then you actually have skin or a bony eruption through skin. Where else do you have then a change in keratinized tissue that erupts through the skin? Your fingernails. Very good. So your fingernails also are another site potentially of an area where skin is interrupted, and there's actually, through that eruption, a keratinized tissue that has an interface with that skin and creates then potentially an opening. Okay? So when we look at these different areas, we can see the skin actually is one of four barriers. There are four barrier systems in the body. The skin is one. The lungs are another. There is a GI barrier or a gastrointestinal barrier. And the final then is what we call the blood-brain barrier. And all of these barrier systems create a protection between the outside world and the inside world. Okay? So think about it, when some of these barriers are broken down, what might afflict or afflictions we might note in the body. For example, if there has been a breach in this area of the tooth and the gum interface, we have periodontal disease or infection that may go then into the bone, and that may require then some type of tooth care or gum care or deeper into the bone care. But when you look at the nails and the interface between the nails and the cuticle and the finger, there's quickly identifiable then many different diseases that may indicate a breakdown in the barrier system. Okay, so we look at those areas as well. For example, people who have what's called onycholysis or fungus along the nail, or you'll see also clubbing of the fingers. Have you ever seen fingers that instead of being basically like this, they actually get raised and foreshortened like this, and they look like clubbed fingertips. Have you ever seen that? You see that most commonly with people who have a smoking habit. Okay? And the fingertips will actually shorten and club like that. Okay? See that often? And then it'll become white or blue or cyanotic, and that will draw or shut down some of those capillary beds. You'll see also with people in the feet that have diabetes, you'll notice in the skin that there will be ulcerations underneath the toes, or sores that don't heal well, sores out on the ends of the toes that don't heal well. And you'll also see then other conditions that are associated with the skin that may be a link into something more extensive that's happening with the system. For example, how many of you have ever seen on a person's neck, or maybe on your own neck, little tiny skin tags? Have you seen those little skin tags that kind of just set up like that, and they just have kind of a little pedunculated head like that? Those skin tags are an indication of something going on within the system. Some people will notice those as they're more advanced. Many will be in the armpit, and they'll see these little skin tags that form in the armpit. Okay, they're very common along the bra line or just underneath the pectoral muscles. Okay, and those are also very common. And this is a very common condition associated with insulin resistance.
Around the eyes too?
Around the eyes, sometimes you'll see those as well. But especially the armpits and on the neck and along this area of the chest and torso. Very, very consistent with insulin resistance, which may be pre-diabetes or may be full-blown diabetes. Okay, so if you know somebody that has diabetes or is diabetic, the more advanced the diabetes, the more skin tags that they'll get in the armpits and along this area of the chest. But you'll see them here on the neck often too. When we see this, oftentimes it's in the insulin resistance, it's an indication of the body's inability to process simple carbohydrates. So breads, pastas, pastries, cookies, candies, juices, things like that. And a lot of times those will just be cut off. Now, the purpose of our course tonight is not to replace a dermatologist in his diagnosis, okay? It's more of a physiologic perspective and what is occurring in the skin. When we start to see some of these sensitivities to foods, the reason we've drawn this epidermal, dermal, basal, or germal layer, what we're actually looking for then is, have you seen when there are little blistering eruptions where they're itchy, and when you break them off, they actually will ooze? And these dermal eruptions are not what we're talking about with sebaceous cysts or acne or folliculitis. This is actually called dermatitis herpetiform. Does anybody know what dermatitis herpetiform is? Or is an indication of? Dermatitis herpetiform is linked to a true wheat allergy. So you'll see it, dermatitis herpetiform, you can look it up as dermatitis herpetiform plus celiac disease. And one of the most common areas that will be afflicted will be the arms, the legs, the torso, but most commonly the feet and the hands will actually have these blisters that will itch terribly. And when they peel them off, they'll actually erupt like a blister, and then it leaves raw skin underneath. But the itch is so terrible that a lot of people will continue to itch those. And I've actually seen people with a blister pattern on the bottom of the feet where they've actually itched and scratched off entire patches of skin, and that whole area will be red raw flesh because that area was a blister, and they'll actually tear off all that skin, and that will actually be just raw underneath it. Very, very, very painful. And that we most consistently see with dermatitis herpetiform, which is an accumulation of immunoglobulin A, IgA, that's setting in there, and that IgA accumulation then will actually erupt the skin as a blister or a vesicle, and they'll itch and scratch at it. They'll be treated with cortisone and all kinds of topicals, but it's actually a problem with a food sensitivity. Okay? Everybody okay to that point? Too much information already? Doing okay. Okay. So let's actually talk about two other things that kind of go through a categorical or a growing up, if you will, of the skin, or maturation of the skin. The most common skin affliction of newborn infants is a condition we know as jaundice. Okay? How many of you have seen a newborn that has jaundice or has that yellowed skin? Everyone should, actually, because when baby is born, baby has been living in this fluid environment wherein this little person is completely dependent on mom to have a little attachment to what's called a placenta to interface the blood circulating through mom to be able to get oxygen to its little body to make it happy. Okay? So in its red blood cells, the baby has a higher concentration of what's called fetal hemoglobin. We'll just put HGB. That fetal hemoglobin allows the baby to live in a fluid environment and not breathe air directly and be able to pull oxygen away from mom's hemoglobin. Okay? If baby's hemoglobin was had the same affinity for oxygen as mom's did, as it passed by, there would be no exchange of oxygen from mom's hemoglobin to baby's. So baby's hemoglobin has an even more magnetic or drawing or affinity for oxygen than does mom's. Such that then once baby has turned into the right position, is delivered, and breathes air on its own, all this fetal hemoglobin has to be released. It doesn't need that high affinity. Now there's a direct exchange with the oxygen in the air. Then the baby has then a rapid die-off of the red blood cells that are the fetal red blood cells, and consequently that rapid die-off causes an immediate yellowing of the skin for the first week to 2 weeks of baby's new life. Isn't that fascinating? But that's why baby always looks a little yellow after those first couple of days. Now when it persists into weeks and a month, then we know that there may be something going on with the liver. Okay? But most often that's what we see with baby, is this yellowed skin appearance, which is actually good. Right? Next thing though, once baby's born, what's the most common skin afflictions that we see with newborns? Little cradle cap, huh? So that cradle cap can also be one of two things. A severe cradle cap, usually the baby you'll see as it comes out from this fluid environment into this dry air, it has to adjust. Okay? So usually they'll lose that first little layer of skin, and then you may see cradle caps. So what we want to look for then is actually on baby's little bottom, looking for a diaper rash. That's usually what we're going to start to find. And that diaper rash for baby is most consistent with a yeast infection. Now, is that a yeast infection that baby has? Typically not. It's a transfer from mom. So in this case, we want to treat mom's yeast infection to be able to get rid of baby's yeast infection. Okay? Unfortunately, what we see a lot of times is babies treated with nystatin and other yeast eliminating drugs, but the yeast is actually in mom. Okay? So where we want to start is with mom. When we look then as baby continues to grow up, now baby's 6, 7, 8 months, and baby's wanting to eat what I'm eating, sitting on my lap, I usually start to feed baby some bananas or some strawberries. Or getting a little bit older, I give them some eggs, or I start to feed them milk in the bottle. And most commonly, what ends up happening when they start to be introduced to these things? Food allergies that come out as a condition called eczema. Okay?